What we're going to do now is go inside and look at an actual example of how some thinking is going on in an organization here in California. And I'd like to just quickly introduce our next speaker, Robert Lerman. Robert, of course, is a doctor. We can all agree on that. And he did his undergrad work at some California school that begins with an S. He's got a residency in internal medicine. He's done fellowships in cardiovascular disease and clinical cardiac electrophysiology, which is something I read up on most nights. Really, most importantly, though, in all seriousness, Robert, he's part of a group of new physician leaders. There's a lot that has to be done, whether you agree with what's happening in the way healthcare is changing or not, where the importance of physician leadership stepping up is really critical. Dr. Lerman is one of those leaders. He's a vice president and medical director of physician integration at Dignity Health up north here. Without further ado, join me in welcoming Dr. Lerman.
The first strategic decision is to decide whether to put the glasses on or off, depending on where the monitor is. It may change. Healthcare is fluctuating. So anybody out there have teenage children? Hands up, a few. Okay, so I have a 17-year-old, and over the weekend, he said, Dad, can my friend Jane come over for dinner and to have a movie night? And so my wife and I said, sure, no problem. But by the way, I mean, what's the relationship here? Is Jane a friend or a girlfriend or a friend girl or what? And he said, no, she's just a friend, so that's fine. So Jane comes over, very lovely girl. We have dinner, and they go upstairs to the den to watch the movies, and I'm working on putting together this talk. And 45 minutes later, my wife says to me, Rob, what do you think they're doing in there? And I said, they're watching a movie. She says, no, what do you really think they're doing in there? I said, look, it's 20 feet down the hall. There's no lock on the door. They're watching a movie. She says, well, go check on them. I said, I'm not going to go check on them. You go check on them. She says, no, I'm not going to go check on them. You go check on them. So this is kind of what we came up with. They were watching a movie. So yes, I am a doctor. I put this slide in to remind myself before I switched out my scrubs for a suit. But we're going to spend a couple minutes talking about Dignity Health and what we are doing to try to position ourselves for success in what is a challenging environment. So we're trying to move from being a group of hospitals to something more. But the backbone of our system is still 39 hospitals in California, Nevada, and Arizona. We have about 9,000 affiliated physicians, about 50,000 plus employees, and we are a mission-driven organization. We delivered about $1.6 billion in care to the poor last year. We live in some very competitive neighborhoods. We have, in Northern California, Kaiser and Sutter, which are excellent organizations that have mature medical group structures already affiliated with them. In Southern California, of course, Kaiser is still there, but there are also large independent medical groups and foundations that are associated with nonprofit systems and have formed several pioneer ACOs. In Arizona, we have a very formidable Banner Health System, who also has an employed physician group and has multiple ACOs. And in Nevada, we've seen health plans and medical groups aligning with independent doctors and growing employed models. So that's kind of the competitive landscape. Dignity Health used to be called Catholic Healthcare West, and you can see up there a little bit of our history. The most important thing is that we changed our name and our governance in 2012, mostly to really clearly define the organization and to position ourselves into what will hopefully be success under healthcare reform. But the most important thing, as far as most of us are concerned, is although the name may have changed, the mission and the vision stay the same. We also, however, did make some internal structural decisions. We used to be very hospital-centric, and the hospital presidents sort of ruled the roost. There was very little overall coordination. We changed that. We changed from a hospital view to more of a market view, moving initially to 10 and now to 9 service areas. So we're focused more on the markets and less in the hospitals ourselves. This allows us to have more of a clinical enterprise focus, and hopefully is allowing us to have more streamlined decision-making, better accountability for outcomes, and ultimately more responsive to community needs. Our overall overreaching strategy is called Horizon 2020. It's where we would like to be as an organization by 2020, hopefully sooner. We want to deliver the right care at the right time, at the right cost to every patient. We want to become America's best health system to work and practice. And we really want to be valued as both a leader and a partner, and hopefully a model of successful reform. So some of you may have seen this picture in Fortune magazine. This is Lloyd Dean, who is our CEO. Now, Lloyd has been an outspoken supporter of healthcare reform for some time. And as you may have heard, that's not necessarily have been the most popular position in the world. Moving right along, 7 strategies we have identified for hopefully succeeding in the new healthcare environment. And those include creating value, increasing accountability, a focus on the patient, leverage technology to drive change, forge new partnerships, transition to an integrated delivery network, and apparently learn how to create PowerPoints on a PC instead of a Mac. That would be number 8. So I think that value is ultimately going to be defined by the consumers, but one definition of what value is health outcomes per dollar spent. And I think the outcomes are the important part because quality is not just based upon process improvement, but actually taking accountability for actual outcomes. And cost control, while important, should not be subjugated to quality. And what we want to do as a system is move from an environment where we're mostly in a fee-for-service or fee-for-volume world, the more we do, the more we get, to delivering true value for the dollars that we receive. As an example of our focus on outcomes is our No Harm campaign, which is part of the HEN program. It's a very interesting name. That we were awarded the Hospital Engagement Network, the CMS program, that has a very ambitious goal of a 40% reduction in hospital-acquired conditions and a 20% reduction in readmissions. So real outcomes here over a 3-year period, and you can see some of the things that we're working on. Obviously, cost is part of the equation. Over the last couple of years, we have what we call our clinical operations improvement. And the idea here, again, is part of our concept of becoming a little bit more standardized. So we develop system-wide guidelines, again, more guidelines, and strategies that we then standardize across the system and figure out how to implement into an individual hospital's workflows. And those are some of the work streams that we've been working on for the last couple of years. So the second strategy is to increase accountability. Now, part of that is actually a transition into the world of accountable care delivery. And we want to move from the current state where we're in mostly episodic care, fee-for-volume, fee-for-service, mostly focused on our hospitals, to a future state where we'll be focused mostly on managing populations, where we'll have a diversified and integrated delivery network. So I really think that the old model of stakeholders is going to be obsolete when we're all in our individual silos, and we're going to have to really take collective accountability and ultimately be accountable to our patients. But part of that is really a joint accountability. And from my standpoint, what that means is that we have to be responsible to one another. So if I'm in a community as a hospital, where I have leverage. It doesn't mean that I'm going to gouge Sam and WellPoint, and hopefully if he's in a situation where he has the leverage, he's not going to try and take advantage of us. I think really, in order to be successful moving forward, there's going to be a whole lot more collective responsibility. Focus on the patient. We've heard a lot about that, especially in the last session. We agree 100% with that because I think it's going to be impossible to make significant changes in healthcare without engaging the patients, and it's going to require broad spectrum engagement. So at Dignity Health, we're really focusing on a number of different things. We're taking a fresh look at our primary care delivery system with emphasis on patient-centered medical homes and medical neighborhoods. We're trying to increase access to our patient through patient portals and telehealth. We have formed patient and family councils. We heard about Kaiser and their shared decision-making. We are doing much the same thing to involve patients and families in treatment choices. And we're supporting development of some of our entrepreneurial partners in patient-facing tools, such as a texting tool for diabetes and Asthmopolis, which I'll talk about in a couple minutes, as an exciting technology to help patients with asthma. So this is just a couple examples of what we're doing. This is our consumer portal, which is importantly going to include an app. So now we'll have an app for that. This is an example of our patient portal. Nothing that is necessarily earth-shaking other than we haven't had one, and now we will, which is a good thing. So the fourth strategy is really part and parcel of that, leveraging technology to drive change, because we think that each one of the innovative payment reforms really depends upon physicians being able to manage risk and report outcomes. And it's very difficult to do that without technology. So we think that data will allow decision-making based on comparative effectiveness. We think that real-time decision support is going to be available, and that's going to reduce variations in care and more guidelines. And then we'll be able to have our physicians use analytics to risk stratify a population, which will allow targeted allocation of resources based upon the level of risk. And we're also very, very supportive of mobile technology and telehealth, which we think are going to create not only human wins, but in fact financial wins. And for example, the last one, this is our telehealth neurology program up in Sacramento, and you can see that there's a robot with our remote neurologist who is talking to the patient. This program was actually initiated by a philanthropic grant dedicated to helping us improve stroke care in the community. And what we elected to do was to leverage our strength in tertiary stroke care in some of our Sacramento area hospitals to help out community hospitals who just didn't have neurologists at all. And we've had really excellent success with the Guidelines campaign for stroke. And interestingly, not only has this promoted transfers to our hospitals for acute stroke, but there's been an additional benefit above and beyond that of additional transfers for neuroscience unrelated to stroke care. So it's had both a human effect and a beneficial financial effect. We are very dedicated to forging new partnerships. And one of the things that, if we're talking about forecasting the future, we don't think that anybody's really going to be able to go at it alone. Certainly not from the provider standpoint. It's just too hard. It's just too complicated. So we want to be able to work with best-in-class partners where their health plans, academic centers, community centers, entrepreneurs, regardless, we want to be able to partner with a variety of different people to move forward on common goals. So for a couple of years now, we have had the commercial ACO in the Sacramento area with CalPERS, the largest employer in California, with Blue Shield of California, with the Independent Hill Physicians Group, and with ourselves. We have some joint ventures with USPI and SimonMed, and last year we completed the acquisition of US HealthWorks, which is the largest provider of occupational medicine in the country. And we have our first Medicare Shared Savings ACO in Arizona, which is with a completely different health system, with Abrazo, which is part of the Vanguard system. More partnerships are with United Healthcare to create Shared Clarity, which is an organization that is going to create true comparative effectiveness studies for device purchasing so people can really know what works. And we also partner with entrepreneurs such as Asmopolis, who creates an inhaler or a GPS device that you put on top of an inhaler, so when patients have asthma exacerbations, the patients and the physicians know when it's happening and where it's happening. We're going to transform ourselves and are in the middle of transforming ourselves to an integrated delivery network. We're going to grow our foundation, partner with our independent physicians in clinical integration, which I'll touch on in a second. We've talked about joint ventures and primary care redesign, and we're also working with health plans around their strategy for the healthcare exchanges and focusing on IT integration as well. I'm going to spend the last couple of minutes talking about clinical integration because that's actually my day job. We think that clinical integration is really the bridge between the fee-for-service world and the accountable care world. And it's a major part of our physician strategy. We're not going out there buying a lot of practices. We are partnering with our independent physicians. And this is basically how it works. The physicians form a coalition of independent and group physicians that partner with the local hospitals. The physicians themselves select quality and cost goals, usually 5 to 10 goals per specialty across the continuum of care. They share data together, monitor compliance, and work for performance improvement. From a strategic standpoint, it creates the physician infrastructure, the IT infrastructure, and the quality infrastructure that will allow our physician partners and our hospitals to go in whatever direction is appropriate for a given market. So there are some markets that it may be appropriate to stay in the fee-for-service world, whereas others might be appropriate to move aggressively into accountable care. It will also position us to move forward into population health management when and if it is appropriate. And as you can see here, and I won't really dwell on this, there are benefits to all the major stakeholders, whether it's the physicians, the hospitals, the payers, employers, or ultimately, and most importantly, the patients. We're pursuing clinical integration in 7 of our 10 service areas. We have been to the FTC with 3 of the programs. We've got about 2,300 physicians enrolled. So far, we'll probably double that by the time we're done. So in conclusion, Dignity Health is a mission-driven organization with a proven commitment to the poor and disenfranchised. We're now an integrated operating company with the ability to quickly implement change, and hopefully that will position us well to adapting in a healthcare reform environment. We are committed to creating value and quality care to our patients, to improving the patient experience, to leveraging technology and new partnerships, and the transition into an integrated delivery network to hopefully position us for success in the new and challenging environment. Thank you.